Neurology quiz number 91. Describe the pathogenesis, clinical features, and management of adrenoleukodystrophy, or ALD. ALD is a genetic peroxisomal disorder resulting from abnormal metabolism of very long-chain fatty acids. It is usually inherited as an X-linked recessive disorder. The brain, spinal cord, adrenal gland are the most commonly affected organs. It is caused by a mutation in the gene ABCD1, which leads to a deficiency of the peroxisomal transporter ABCD1, leading to accumulation of very long-chain fatty acids. Rare cases occur in women and are caused by X chromosome inactivation. It is of three types: cerebral adrenoleukodystrophy, adrenomyeloneuropathy, and adrenal insufficiency only. Cerebral adrenoleukodystrophy typically affects boys aged 3 to 12 years. It is characterized by new onset of behavioral and fine motor difficulty. Clinical features include inattention, emotional lability, and academic difficulty, as well as clumsiness and change in vision. In some cases, seizures may occur at onset. In the early stages, patients are often mistakenly diagnosed as attention deficit disorder. Within months, there is progressive and irreversible impairment of motor and cognitive function. Associated adrenal insufficiency is seen in many cases. This can lead to growth retardation in symptoms such as fatigue, nausea, vomiting, weight loss, as well as hypotension and hypoglycemia and hyperpigmented skin. Investigation: increased levels of very long-chain fatty acids are noted in the plasma. However, this can be a non-specific finding, and they are also elevated in other peroxisomal disorders. Low plasmalogen levels are noted in the RBC. Lab tests may show evidence of associated adrenal insufficiency. MRI brain: this shows T2 and FLAIR hyperintensities, which initially appear in the splenium of the corpus callosum and then extend into the parieto-occipital white matter. Lesions are associated with contrast enhancement, which indicates active disease and is related to inflammatory changes. The extent of MRI abnormality can help guide therapeutic options. Diagnosis is confirmed by genetic testing for mutation in the ABCD1 gene. In this slide on the left, the MRI shows the typical confluent and symmetric bilateral hyperintensities in the white matter of the parieto-occipital regions and corpus callosum. On the right side is the second pattern which may be seen, in which white matter lesions can occur in the deep anterior frontal white matter. This slide shows an MRI which shows occipital demyelination, which exhibits contrast enhancement. Treatment: a recommended treatment for asymptomatic or minimally symptomatic cerebral adrenoleukodystrophy is hematopoietic transplantation. Because of the need for early identification and intervention, adrenoleukodystrophy was added to the recommended uniform screening panel in 2016. Screening MRIs are recommended throughout childhood for identification and monitoring of cerebral involvement. It is recommended that annual MRIs should be performed yearly at 1 year of age and transition to every 6 months between the ages of 3 and 12 years. Goal of screening is to identify lesions when they are pre-symptomatic and to allow for identification of active lesions that require intervention. Gene therapy: Elevaldogene autotemcel or Skysona is the only approved gene therapy for cerebral adrenoleukodystrophy. It is indicated in patients with early and active adrenoleukodystrophy, 4 to 17 years of age, and slows the progression of neurologic dysfunction. It is prepared from the patient's stem cells and given intravenously as a one-time dose. Pre-treatment chemotherapy is required. It provides functional copies of the ABCD1 gene. Supportive care by optimizing nutrition, outpatient therapy, and respiratory support can help to treat some of the more severe consequences of the disease. Replacement therapy is needed in those with impaired adrenal function. Adrenomyeloneuropathy: this form is primarily seen in adults in the third decade. There is progressive demyelination and atrophy within the spinal cord, especially in the corticospinal tracts. Changes may also be noted in the cerebral white matter, and lesions are seen in the posterior limb of the internal capsule and splenium of the corpus callosum. The radiological lesions may show contrast enhancement. Clinical features include progressive difficulty walking as well as sexual and urinary dysfunction. Some patients may exhibit features of cerebral dysfunction, such as behavioral abnormalities, seizures, and visual changes. Neuropathy can occur. It is usually mild, manifesting as distal paresthesias in the extremities. A milder and late onset form is seen in women and sometimes also in males. As in cerebral adrenoleukodystrophy, there may be associated adrenal insufficiency. Treatment involves replacement therapy for adrenal insufficiency as well as supportive care. This slide on the left shows a case of adrenomyeloneuropathy, spinal MRI showing thinning and atrophy of the dorsal spinal cord with relative sparing of the conus medullaris. On the right, it shows brain MRI in the same case, which shows bilateral confluent white matter frontoparietal hyperintensities.